Hi, my name is Jess Howell, and I'm with the pharmacy today. So we have a mutual patient, 54-year-old male, Greg Lawson. His chief complaint is, I feel so hopeless, the antidepressant just isn't working. He is in the ED today for being depressed after a separation of his wife from last year while being on multiple antidepressants. The patient has taken duloxetine, escitalopram, venlafaxine, and most currently sertraline, so he's taken SSRIs and SNRIs. He states that he doesn't really have anything going for him. He has no sex drive, and he is no longer taking the antidepressants. He can't get out of bed some days, and he sleeps about 8 to 10 hours a night. He denies SI and HI, and he also reports to adherence to medications. Past medical history includes type 2 diabetes, diabetic neuropathy, hypothyroidism, and depression. His family history doesn't really have any significant anything to report other than the mother also had depression, so it could be a genetic link there as well. His social history, he is disabled. He was a previous construction worker. He's been recently separated from his wife. He doesn't have any children. He drinks 3 to 4 beers a month, maybe more depending on the week, is what he said. He has an allergic reaction to glyburide. It causes hypoglycemia, but it's not really an allergic reaction. It's like part of what could have caused his hypoglycemia was being on this medication, glyburide. He had taken sertraline 150 milligrams. He took 1 tablet by mouth daily for 10 weeks, and then he self-discontinued a few weeks ago. He takes levothyroxine 50 microgram. He takes 1 tab by mouth daily for 2 years, and his last dose was today for his hypothyroidism. For his diabetes control, or his current diabetic regimen, is metformin 1000 milligrams. He takes 1 tablet by mouth twice a day with meals. He's been on that for 3 years, and his last dose was today. He also takes gabapentin for his diabetic neuropathy. He's on gabapentin 400 milligram capsule. He takes 1 by mouth 3 times a day for a year, and his last dose was today. He also is on atorvastatin 40 milligrams, 1 tablet by mouth daily. His last dose was yesterday for his cholesterol maintenance. For his immunizations, he had his Tdap vaccine 3 years ago. He had his annual flu vaccine 6 months ago. And he's been fully vaccinated, boosted against the COVID-19 virus. He also received all his childhood vaccines, so he's currently up to date on all childhood vaccines and everything else. Review of systems, he has a PHQ 9 score of 15. And he's had no improvement since his diagnosis. He does drink a few beer a few times a month, but with that score, that puts him in the moderate to severe category for depression, and we kind of want that number less than 5. So generally, he's depressed and he's tearful, and he was tearful whenever he was talking about his wife and the relationship, and would have been better if he was home more with her. Extreme pain score was a 3 out of 10. He feels the meds are controlling the tingling in his feet as well. His blood pressure is 110/83 mmHg. I like that. He's below goal. His blood pressure looks good. His heart rate is 76 beats per minute. His temperature today is 97.9 degrees Fahrenheit. His resting, his RPM is 17 beats per minute. And then he's 5'10". He weighs 209 pounds. His BMI today is 30 kilograms per meter squared. His serum creatinine is 122 ml per minute, which is really good, so we don't have to worry about any renal issues with this patient. Although his hemoglobin A1C is 8.1%, which is high, we always want that below 7 if we can get it. His LDL is slightly elevated too. It's 160 milligrams per DL, and we want the goal less than 30. His total cholesterol is 210 milligrams per DL, and that's high because we want it less than 200. Any tox screens, he was negative for barbiturates, benzos, cocaine, marijuana, methamphetamines, opiates, and oxy. So my number one problem with this patient is his depression. Based on that, the PHQ 9 score of being 15, he's experiencing moderate to severe uncontrolled depression. Patient has taken SSRIs, SNRIs, and those drug classes did not show any improvement with him. So my goal, or what I want to do for this patient, is let's put him on Wellbutrin or bupropion, 150 XL extended release milligram tablet. He's just going to take 1 tablet by mouth daily according to the APA depression guidelines in 2010. Wellbutrin is another first-line option for patients since norepinephrine and dopamine receptor inhibitors They act in different parts of the brain than like SSRIs and SNRIs. They kind of work more towards, serotonin. So the insurance does cover the Wellbutrin XL150, which is why a great option for this patient. So the plan is to improve his quality of life. We want to decrease that PHQ-9 score of less than 5, and we want to improve sexual dysfunction, which will help with the patient being on bupropion, because some SSRIs and SNRIs do cause sexual dysfunction and like decreased libido, but Wellbutrin's a good line to combat the depression and that as well. So we'll put him on bupropion, 150 milligrams XL, 1 tablet by mouth daily. We're going to do it indefinitely until he reports it's not working or it's just not right for him. Some safety and toxicity monitoring I want to go over is like monitor for weight loss. Like more than 28% of patients experience this. It's like more like 5 to 10 pounds he could lose. He can have nausea, vomiting. This also lowers the seizure threshold, but he doesn't really have a past medical history of any seizures, so I'm not worried about it as much with him. Bupropion is a CYP2D6 inhibitor, so we want to watch out for drugs that inhibit that as well. We also want to monitor suicidal ideation. We kind of want to do that every 1 to 2 months as well. So efficacy and improvement in monitoring. So bupropion does improve sexual dysfunction, and he should be seeing improvement with his MDD within 1 to 2 weeks. There's also no like current drug-drug interactions between any of his current medlets while being on bupropion as well. All of my sources here were from LexiComp, and if the patient has any sertraline at home, just kind of want to counsel him and say, like, don't take the sertraline and bupropion together. Just take the bupropion, so then now we know, like, other providers, like, it's been discontinued. So that's all I have for his depression. So for his diabetes, that's another problem I want to go over. His diabetes is obviously not well controlled with the concurrent use of metformin. His A1C is 8.1%. Like, we want that below 7. And he's already on the first line therapy for diabetes, like oral medication wise. And his A1C is still obviously not well controlled. According to the ADA guidelines in 2023, he should be put on SGLT2 inhibitor. He doesn't really prefer any like injectables for his diabetes maintenance, so we're kind of limited to oral medications, but the sodium, the SGLT2 is something that I like and I'm familiar with, and I want to put him on that. So the plan is to get his blood like A1C less than 7. We're going to put him on Farxiga 10 milligram, 1 tablet by mouth daily. We're going to keep the metformin on top of therapy, so we're not going to discontinue anything else. The insurance actually covers Farxiga, and that's kind of like the first line in their formulary that they want to cover. There is also no drug-drug interactions by adding Farxiga on top of his Wellbutrin and the other maintenance meds that he's on. So we're going to do Farxiga, 10 milligrams, just 1 tablet by mouth daily. We're going to do that indefinitely until we get his blood sugar under control. We can adjust, add whichever one we prefer, like when the time comes. So some important like safety and monitoring I want to go over is like monitor for UTIs, especially. There wasn't anything in his past medical history that showed me that he had a like previous history of UTIs, but we need to monitor for that. We need to watch his volume status. He doesn't drink beer or like drink alcohol as much, but we still want to make sure he's like maintaining adequate like volumic status as well. His renal function again is fine, but we want to make sure like his kidneys, if they worsen and progress, we need to figure that out and dose adjust as needed. We need to monitor his hemoglobin A1C like twice yearly and make sure that's under control. This can also cause nausea, dysuria, back pain, nasopharyngitis, and especially with his metformin, he probably wants to avoid alcohol, even though he doesn't drink that much anyway. Some efficacy and improvement with Farxiga is this should start working within 1 to 2 hours to reduce his blood glucose. We want his pre-prandial glucose to be between 80 and 130 mg per DL. We want his post-prandial or post-eating glucose to be less than 180. And like with Farxiga, this does have an ASCVD benefit. And the patient's current ASCVD benefit is 10%, which is like in the moderate category. So I mean, like as you get older, that number does increase and you do progress. And again, these sources from LexiComp. What questions do you have for me? I'm good to change, I'm good to alter, but I definitely want to put them on the bupropion and the Farxiga. So let me know if you have any questions.